Good afternoon, everyone. We will start in 1 minute. Good afternoon, everyone. My name is Ziad Kazi, and I am your host today from Atlanta for the ACMT Grand Rounds webinar that is usually hosted by Dr. J.J. Ratimus, and it's my pleasure today to assume his responsibility and introduce our speaker today. The topic today is oximes. I have not used any in a decade, and our speaker is Dr. Ashish Balla, Professor of Medicine, Chief of Emergency Medicine, Medical Toxicology at the Postgraduate Institute of Medical Education Research in Chandigarh, India. Dr. Balla is here in Atlanta and Emory for the next 10 days, and then will travel to San Juan, Puerto Rico to attend the annual scientific meeting. His visit is sponsored by Pfizer Inc. This is the program that they sponsor, and the title of this proposal that we submitted to Pfizer Inc. was Visiting Professorship in Global Toxicology. We submitted this proposal with the purpose of enhancing dialogue and collaboration and exchange expertise and clinical experience between the U.S. and India. We each have our own clinical exposures and experiences, and the goal of this grant was to foster this type of dialogue and enhance our knowledge in the U.S., as well as potentially also enhancing the knowledge in India through this exchange. Both Dr. Balla and myself do not have any conflicts of interest to disclose relating to this activity. The session is being recorded. I prefer to leave questions till the end, where I will have a better way to monitor the chat column as well as the question and answer column. But if you have a burning question or you want to interject, please feel free to do that. I will try my best to identify these raised hands or these chats. You also may find me interjecting myself a little bit because we're hoping to make this a little bit interactive and moderated, kind of like a podcast, but not really. So I apologize ahead of time for any interjection, but when useful, I will try to make those points. We have about 52 slides, and we should have plenty of time for questions and answers at the end. And I believe I can turn it over to Dr. Balla.
Good afternoon, everyone. It's an honor to be here today and to talk to you. I bring greetings from City Beautiful, that is Chandigarh. It's located in the north of India, around 250 kilometers away from Delhi. And it's the first city in India which was planned, designed by the French architect Le Corbusier. It has got an area of around 120 square kilometers and have around 1 million people staying there. I work at PGIMER Chandigarh, that is Postgraduate Institute of Medical Education and Research. Got around 2,000 beds there, and in the emergency we have nearly 50,000 patients coming in every year. And on average we see around 1,500 cases of poisoning, and out of them the most common poisoning we encounter is pesticide poisoning, and majority of them are organophosphates. I work with INDOCM, that's the Indo-US Emergency Medicine Collaborative, with Emory University, CDC US and American College of Medical Toxicology. We worked at various stages in our life in India and abroad, and we've collaborated on various topics of interest.
And some of you may have seen in the slide Dr. Paul Wax, who's really well dressed in this photograph from the Agents of Opportunity course in Delhi.
And you see we are sitting there.
But I'm not as well dressed as Dr. Wax.
Okay, coming to the topic itself, agriculture is big in India, just like it is big in US. India is 2.4% of the land mass. Population has increased to 1.2 billion. And the use of pesticide is around 75,000 metric tons every year. Our economy depends mostly on agriculture, so to prevent the pests from destroying the crops, we use lots of pesticide, but it ends up destroying lots of lives of the farmers and their near and dear ones. Doesn't only stop there. This is a carbamate, which is commonly found in most of the households. It's used to kill, the powder is used to kill the flies, and the liquid is used for indoor spraying to kill the mosquitoes. So it is available even in, not only in the farming community, even in the urban areas, in the houses, it is available readily, and people do end up ingesting them whenever they are stressed and come to us in a state where they are overdosed. The Insecticide Act was introduced way back in 1968, and it was aimed at regulating the import, manufacture, sale, transport, distribution, and use of insecticide in India. And under this act, it is statutory to notify the acts of poisoning to the Ministry of Agriculture. No nationwide statistics are available. Majority of the available studies regarding the pattern of poison comes from northern part of India. There are some studies now which have come from the southern and the central part of India, but a little information from the other areas. The biggest flaw of these studies is they are all hospital-based studies. There is no community-based data on poisoning or overdose. We have only 4 poison centers across India, and the data is still not collated from all these sources. The other source is the police statistics, as suicide is an offense, and every suicide attempt needs to be notified to the police. The Ministry of Agriculture, for the first time, July 1999 to June 2000, kind of took out a project which looked at the exposure to pesticides in various parts of India, and these are the centers which are displayed here. 1,530 cases, 73% males, and found that organophosphate was the highest kind of poison which was involved, self-harm, and the next common was aluminum phosphide. Majority were the suicidal attempts or the attempts at self-harm. There were some accidental occupational exposure also. Now this is the data which was first published from our institute between 1970 to 1989, around 870 patients over the age of 12. Mean age was 26 years, although the range was quite wide. But you'll see that most of them are young males in their productive years of life. They belong to lower middle socioeconomic status, and majority of them come with self-harm. In the decade from 70 to 89, it was 75%, 17.5% was the mortality, which increased to 1980 to 89 to 29.5%, and I'll come to it a little later why this change happened. There's another study, which is a forensic-based study, autopsy data, which also talks about that in the years between 77 to 87, we used to see barbiturates as the main agents of self-harm, followed by organophosphates and copper sulfate. But over the next decade, it was organophosphate and aluminum phosphide, and now barbiturates are almost never used. We hardly see any barbiturate or copper sulfate. Maybe one case in 2 or 3 years we come across these cases. The reason why mortality increased from 1980 onwards was the fact that aluminum phosphide was introduced into the market as grain fumigant, and we'll come to it a little later why that is important. If you look at the pattern of poisoning according to the month in which the poisoning cases are reported, you'll find 2 peaks. One is in March and the other is in August. March is the time and August is the time when wheat and paddy respectively are harvested. So that's the time when the crops fail, and that is the time when majority of the farmers would end up harming themselves because they are financially kind of in a mess. This is my study from 1990 to 2004, nearly 3,000 patients. Mean age remains 28 years. Organophosphate and carbamates were around 35%, and aluminum phosphide was 26%. The highest case fatality recorded was with aluminum phosphide. It decreased beyond or declined beyond year 2000 because there was a simple step taken by the government that the tablets was kind of replaced by granular form, and whenever you have a granular form of aluminum phosphide, this powder form you can't ingest. You need to dissolve it in some liquid. The moment you dissolve it in water or milk or juice, phosphine gets released outside and not inside the body. So that was one important step which prevented mortality or led to decrease in mortality. Now let's see this case, which is a very typical kind of a presentation in our ED. A middle-aged farmer who had a failed crop is brought in the morning by a son in a taxi, because the ambulance service is not very well developed, from a village which is around 5 hours away by car, by road, to us. He was found unconscious in the evening after returning from the fields. He is a chronic alcoholic and he was drunk at that time when this happened. He vomited 3-4 times, was frothing at the mouth, salivated, and was agitated. With these complaints, something was abnormal, was thought by his son, and he was taken to a local hospital. It is mandatory, since it is to be informed to the police, it is mandatory by law to collect a gastric lavage sample for these patients. So that was done in the hospital. He was started on IV fluids. He was given atropine 4 ampoules every 15 minutes for over the next 45 minutes, and then he was referred to PGI. Now this patient comes to PGI or to our institute, not accompanied by any medical doctor or paramedic, has received only 12 ampoules of atropine and has not received anything in between for the next 5 hours.
Is this something typical of receiving these patients in a delayed manner to your center?
It's very typical, and that is a very important parameter why I do not use oximes. I'll come to it a little later when we are discussing. In the ED, these patients, wherever they are present in the ED, you walk into the ED and you can smell them. There's a typical smell of pesticides or the hydrocarbons which they use to dissolve them. His clothes were soiled with vomitus. He was frothing at the mouth and nostril. He had pinpoint pupils. His pulse was 60 beats per minute and respiratory rate was 20. He had a blood pressure of 110/70 and a saturation of 90% on room air. He had bilateral extensive crepitations in chest, and his Glasgow Coma score was 10. What next? It was thought that it is pesticide poisoning, likely organophosphate compound, because he comes from a village, he's a farmer, has an access to organophosphate compounds. Details of the compounds were not available. He was started on IV fluids, oxygen, the clothes were removed, the body was washed with soap and water. A gastric lavage sample was collected by us also, although it was 5 hours later, and sent for analysis to the police, handed over to the police. An atropine infusion was started at 2 milligrams per minute. He was admitted and transferred to the ICU. So what do we expect now? in this situation. Over the next 6 to 8 hours, we double the dose of atropine every 5 minutes until complete atropinization. And this complete atropinization, the endpoints are not dilated pupils. The endpoints is dry chest, when the secretions in the chest dry up. This continued on IV fluids. Blood sample for various biochemical analysis was done. Cholinesterase level commonly done is a plasma cholinesterase and not RBC cholinesterase, which was for legal documentation purposes.
Why you don't get the RBC?
Very expensive. It is expensive, and the cost of administering this test, and the other thing is that does not actually correlate with the severity or the mortality prediction. And over the next 6 to 8 hours, we watch for complications like aspiration pneumonitis. Now, this patient is an alcoholic who was drunk at the time when he'd consumed this, and now it is 6 or 8 hours beyond that. He's likely to go to the alcohol withdrawal state, or he may get agitated because of atropine toxicity also, because we are giving incremental dose of atropine. And we do check for motor functions, and the simplest possible test which can be done bedside is the neck holding test. If the patient is able to hold his neck, then there are less likely chances that he'll have a significant paralysis of his respiratory muscles. Now, the diagnosis requires a high index of suspicion, the combination of a history of exposure and typical clinical points, typical clinical parameters. But important thing to remember is the patient will tell you he's consumed a pesticide. He doesn't know what type of pesticide he's consumed. We've burnt our fingers because 2,4-D, which is a herbicide, can also cause meiosis, but there is no salivation, there are no other muscarinic symptoms. So if you're only looking for pupils, you will end up in a problem. So you have to know what exact compound these patients have taken. True cholinesterase, that is RBC cholinesterase, does correlate to some extent with the severity of the poisoning at presentation, and more than 25% reduction is diagnostic. But we do not wait for the levels of cholinesterase to come back to us. We start treatment immediately on the basis of the clinical suspicion. There are very many scoring systems which have been used to evaluate the potential problems or predictability of outcomes, like SOFA score or Apache score, but they are non-specific. They are basically used for all critically ill patients. There is only one specific organophosphorus poisoning scale parameter score. This was published way back in 1993. We use it at PGI, but there are very few institutes which end up using this. It's a very good scoring system, and it talks about it's based on pupillary size, presence of fasciculations, respiration, bradycardia, the loss of consciousness, and if you have seizures, then you add one more point to it. The maximum score is 10. Now, how do we treat these patients? Decontaminate skin, hair, and GI tract. Now, GI tract decontamination is a little controversial. You reverse the effects by using atropine. You give supportive therapy. You can use reactivation by enzymes, and extracorporeal elimination is doubtful. You really can't eliminate organophosphate. Now, when we talk about the antidotes, what is it that alters the absorption? Gastric lavage. Now, if the patient has come to you early in the course, within half an hour or 1 hour of ingestion, then you have a chance to remove the poison from the stomach by using a simple nasogastric tube, because it's a liquid, it will come out. And we've used a nasogastric tube with small aliquots of normal saline or water, and we have shown that it is pretty safe. If the patient comes to you late in the course, and if the patient is unconscious, you want to perform gastric lavage using large volume of fluid, this patient will end up aspirating. So if you have a patient who's comatose or a GCS of less than 9, it's better off to intubate and then do a nasogastric aspiration. Activated charcoal has no role. Reversal of muscarinic effects, we'll see, we can use atropine or glycopyrrolate. 2-PAM is controversial, and we'll talk a little bit about the newer antidotes. Atropine, we use 2 milligrams every 5 minutes, and we double the dose every 5 minutes. The endpoints I've already said is dryness or clear lung. We use it for 24 to 48 hours and always taper, never stop abruptly, and watch for complications of atropine overdose. This is a study which was published from Bangladesh, and they looked at rapid incremental dose of atropinization. And after complete atropinization, you start and maintenance infusion, maybe start at 1 to 2 or 4, 3 milligrams per hour, and then maintain that level of atropinization for next 24 to 48 hours. And that helps in decreasing or controlling the muscarinic symptoms, and that helps in decreasing the mortality in these patients. You can use atropine or glycopyrrolate. The only concern is the cost. Glycopyrrolate is much costlier as compared to atropine, but it's likely to have lesser CNS effects, which are more pronounced with atropine, but the cost always takes precedence in our institute. We end up using atropine more commonly. Why should anyone use oximes? Now we all know that organophosphates, they inhibit acetylcholinesterase enzyme, so there is more acetylcholine. So what if you have more cholinesterase at neuromuscular junction? Would that help? Michael Edelston's study, which we'll talk about a little later, has shown that although there is increased acetylcholinesterase available, the regeneration has occurred, does not translate into mortality benefit. What is the reason? Is it only oximes, or is there something else which might be working at causing mortality? Whether there is a cleaving of enzyme or whether there is a clearance of organophosphates over a period of time which helps in mortality, whether oxime administration causes rapid reversal of symptoms, these are the questions which are still not clearly answered. And which oxime you're going to use. For the nerve agents, obidoxime works beautifully in laboratory settings, right? But obidoxime is not available commercially to treat most of the organophosphate patients. We use 2-PAM, but the people say that it is like comparing not even apples and oranges, it's like comparing a big orange with a small orange. So they are oximes, but they may be less potent. But majority of the data is available, research data is available only with 2-PAM. So we cannot comment on obidoxime. Do oximes work? It depends on the type of ingested compounds, because diethyl compounds and dimethyl compounds, they behave differently. The aging occurs much easier or later, and the duration at which you initiate oxime therapy, the amount of oximes to be instituted, the type of oximes, and the plasma level. Now, the only study in the world which talks about the plasma level of oximes and its effects on cholinesterase regeneration is again from Germany. This was a dog experiment, and they said that if you have a plasma concentration of less than 4 microgram per ml, it was shown that it will not reactivate acetylcholinesterase. So that is why you need the concept of infusion of oximes came in. But this was only one study, that too an animal based, and was done somewhere in late 60s or early 70s. After that.
And is this a study that correlates with the WHO recommended infusion rate?
This is the only study on the basis of which the WHO recommends the rate at which oximes needs to be infused.
7 milligram per kilogram per hour.
Yes. A tribute to my mentor, Dr. Sujit Singh, who's a very famous toxicologist in India and in the world. He asked this question for the first time in 1995, is atropine alone sufficient in acute severe organophosphate poisoning. 18 patients, the mean duration or mean dose of atropine on day 1 was nearly 180 milligrams. And if you look at the range, in 24 hours, some of the patients received up to 500 milligrams of atropine. And the mean duration of treatment with atropine was up to 9.6 days. In another study, when they started aggressively atropinizing these patients, they went up to 800 milligrams of atropine use on day 1. And the range was between 85 to almost 3,000 milligrams of atropine in 24 hours. They used 2-PAM infusion, WHO recommended dose. They used the duration of mechanical ventilation was almost 130 hours, and the mortality when we were using 2-PAM was 12.5%. Now remember this figure when I come back and discuss what is the mortality now. When we don't use 2-PAM, you will realize why I'm not using oximes. This was a paper published in 2005 from another center, CMC Vellore in India. They also do not use 2-PAM, and they said that 2-PAM treatment does not make any difference in butyryl cholinesterase reactivation or complications of moderate or severe organophosphate poisoning. So they have not been using since then 2-PAM. Only 2 institutes in India, or 3 now, AIIMS in Delhi, we don't use. This was a study which caused all the confusion. Kirti Pawar's data, and 100 patients, 50-50 in 2 arms. In 1 patient, they used a bolus, 2-gram bolus, followed by 1 gram every 6 hourly. And the other group, they used 2 grams bolus and 1 gram every hourly for next 48 hours. That means around 50 grams of oximes in 48 hours in the patient. And this is the only study which had shown that the mortality decreased from 8% to 1%, where high-dose PAM was used. Following this, Michael Edelston, who's a very dear friend, and Peter Ayer, they performed this study. They used a lower infusion dose. They did not use 7.5 milligram. They used 0.5 grams per hour of oxime infusion, and they used it for 7 days. They did show that there is a cholinesterase reactivation, but somehow they find that mortality was more in the group where they used oximes, and they have not said what is the reason for that. So oximes became controversial. We didn't know what was the dosage, what was the duration, how it was to be administered. So another dear friend, Nick Buckley and Michael Edelston and Yi from China, they performed this Cochrane analysis in 2011. They reviewed all the available data, and their summary said that there is nothing to suggest that this WHO regime of 2-gram bolus and 7.5 milligram per kg infusion does have any benefit. A study from Kashmir in India, they compared the WHO regime with saline as placebo, and they found that the mortality did not differ in their group as well. So this is my experience, 170 cases over the last 3 years. This we presented in 2014. So no PAM, only atropine, and mortality was 9.6%. When we were using PAM, it was 12.5%, and that was in respiratory ICU. This is in high dependency unit attached to the emergency with us. So why they don't work in some studies or not? So this is what is the risk. I've published this data, it's available. But if you look at, these are the only 3 RCTs, Pawar et al., Mahesh et al., and Soumya Said. They used, Pawar et al., they used almost 50 grams of oximes over 48 hours. 61% of their patients required ventilation, and the mortality was 8%. And when they used this, not the infusion, the bolus doses, 6 hourly. When they used infusion, the ventilatory requirement was 2.7%, and the mortality decreased from 8% to 1%. However, in all the other 2 studies, the mortality has remained with the bolus dose of PAM given every 6 hours above 20%. In one study in 2012, the 8 milligram per kg per hour infusion given over 5 days, the mortality decreased to 10.8%, still higher than 9.6% which I see at my institute. This is comparing the bolus. These are 4 studies which talk about the bolus administration, and you see that the mortality does not differ. So giving a 2 gram bolus and then 1 gram every 6 hourly as an intermittent dose over next 48 hours is probably more harmful, is not able to sustain the oxime levels in the blood and may be harmful. That's why probably, and in Michael Edelston's study, the dose use was less. So probably that caused more mortality in that study. This is our data. This is from Peter JV, the CMC, the other center which do not use the oxime. Their mortality is 10.8%, our mortality is 9.64%. But look here, the delay in institution of treatment at my center is nearly 10 hours, nearly 10 hours. That much time, a mean delay in institution of, or in receiving these patients at my center. So if they come to me 10 hours late, whether I'll use oximes or not going to make a difference. Only one person has tried to address this issue. This is another friend of mine. He's an anesthetist at Aligarh Muslim University. He just did this observational study. All the patients required ventilation, all the patients were admitted to ICU, were ventilated, and he gave them not the infusion, but the bolus doses every 6 hourly, intermittent. And he found that the only thing which makes a difference is delay in institution of oxime therapy. If it is less than 6 hours, the mortality was 0%. If it is between 6 to 12 hours, mortality is 17.1%. That's what I see, around 10%. And if it is more than 12 hours, then the mortality is 28.1%, right? So this is probably the crux. Any other factors? There are studies which have shown that if you have a pyrethroid co-ingestion, if you have an alcohol co-ingestion, it affects the mortality adversely, so there's more mortality. There are studies which have looked at the peroxygenase polymorphism, which is the enzyme which will talk about the which is responsible for metabolism of organophosphate in the body. If there is a polymorphism, you will have delayed clearance of organophosphate from the body, and that's what affects the mortality. Any other additional therapy? No, it does not. So why do oximes don't work? Possibly it depends on the nature of the compound ingested, whether it is a diethyl or a dimethyl compound, whether there are co-ingestants. Maybe we are using an inappropriate oxime. I don't know, because obidoxime is not commercially available. The only thing which is commercially available is 2-PAM, so maybe it is inappropriate. Maybe there is a difference in blood levels. We might need to give a higher bolus, might need to give a higher dose of oxime to maintain a level which will reactivate acetylcholinesterase. But remember, Michael Edelston's study showed that even if there is an acetylcholinesterase reactivation, it does not translate into a mortality benefit. The only thing which seems to work is supportive therapy, and that is ventilation, and delayed institution of enzymes may be one of the factors which might be affecting. Sodium bicarbonate, only studied in Iran, single center, not reproducible. Magnesium sulfate, we did a study and we found that you give magnesium sulfate to patients with organophosphate poisoning, they die more. So do not use magnesium sulfate at all. The role of FFP, role of NAC is all controversial, so we don't use it. What's the point? Is there any side effect of enzymes? The side effects are minimal. There's just dizziness, blurred vision, there might be diastolic hypertension. Does not result in a significant neurological dysfunction, but it is an expensive drug. It's an expensive antidote. So why do you want to use something expensive till the time you're not very sure that it does have any benefit in a given situation? So to evaluate the enzyme therapy, if I need to plan a study today, I would need to know at the earliest that what is the type of organophosphate compound the patient has consumed. What is the poison load? There are no biomarkers which tell me the poison load. Cholinesterase is the only biomarker, but that is poorly correlating with severity. We have to know the time of start, delay in institution of enzymes, and we have to minimize that. That means stockpiling enzymes in the peripheral center where the patient reports earliest. We also need to know the steady state of enzymes in the blood. So we need to have facilities where we can detect and monitor the blood levels of enzymes. We need to find an appropriate dosing schedule and maybe do an animal study to find out at what level there is a inhibition of the acetylcholinesterase gets reversed. And we need to incorporate the supportive therapy which is uniform across the board if we are comparing or if we are using multiple centers, and we need to have meaningful numbers. Having 10 patients in one arm or 20 patients in one arm and 20 in the other arm is not going to give you any meaningful data. So in summarizing whatever I've said till now, is we need to recognize it early, treat promptly. Activated charcoal cathartics have no role. Gastric lavage, if you use a small nasogastric or Ryle's tube, you can collect a sample, but protect the airway if the GCS is low. Atropine is good enough, but if you have some concern regarding the CNS toxicity, you may use glycopyrrolate if you have enough money. Supportive therapy is of paramount importance. Watch for complications. But enzymes therapy, I'm not very convinced. If I have to use enzymes, I will use it in patients who come to me within first 6 hours, who have mild to moderately toxic organophosphate compound ingestion, and I would probably end up giving them a very high dose of infusion over the next 48 hours to maintain a high steady level of enzymes in the blood so that I am able to reverse or reactivate the cholinesterase enzyme. Thank you very much for being with me and giving me the opportunity to present to you.
Thank you, Dr. Balla. While I go through the questions and chat box, can you comment on 2 specific topics of personal interest to me? One is the statement you made earlier today while we were having coffee, that you would definitely intubate and take care of a patient who's obviously contaminated with an organophosphate liquid on their clothing and face, if they require that, without concern for secondary contamination. And then the second question I would like you to comment on is the mild exposures, inhalational exposure, accidental, or maybe a little bit of dermal contact with the liquid. The ones that get discharged, how do you, evaluate them and how long you observe them for?
Okay, the first question, the thing is, do you want a decontaminated dead body, or do you want a contaminated live person whom you've intubated? Whenever we talk about ABC, and airway always takes precedence. What kills organophosphate patients is the secretions. They drown in their own secretions. You need to dry the secretion, and you need to keep the airway open. Suck the secretions out so that they're able to breathe. So I would end up intubating them first. My resident, I've seen thousands and thousands of cases. My residents have intubated them. We use only nitrile gloves, a mask, which is a surgical mask, and gown. And till date, I have not seen anyone developing symptoms while taking care of these patients. Neither my residents nor my healthcare workers, any other paramedic staff. So I would, although your concern is very valid, that you bring a contaminated person into the ER. Now, if he is mildly contaminated, that's the kind of cases you see mostly, and you're concerned about the secondary exposure, decontaminate them. But if a person is drowning his own secretions, I would probably save him first, and by intubating, and then probably take up decontamination. The second question which you asked was
mild cases, inhalation, a little dermal.
You know, these inhalational cases, the thing is that they need to be observed. They need to be observed in the emergency room for at least 12 hours, at least 12 hours. I would not send them back, because you don't know how much of OP has been absorbed through the skin before they've come to you. And they may not have developed the full-fledged symptoms at the time of presentation. They might present to you. Now, the biggest error which you can make is to classify them as acute viral gastroenteritis, because they're vomiting and they're having diarrhea. So that they're the most common symptoms, muscarinic symptoms with which they'll present. You might miss salivation, you might miss lacrimation, but any patient who's come to you with this kind of a history, I'd probably like to observe him for some time. If there is a history or a chance of him being exposed to organophosphate compounds.
Thank you. We have a question from UVA. What is the role of benzodiazepines, and are you infusing them at high doses or any dose empirically?
Interesting, very interesting. Somebody asked me the same question. When you're intubating, how are you intubating these patients? You know, or if they are agitated, what would you use for sedating them? I would use benzodiazepine. The only concern with benzodiazepines in an agitated patient is respiratory depression. If the patient is in intensive care unit or is intubated, I'm not concerned. If I've secured his airway, I'll give him benzodiazepine to sedate him, to calm him down. I would use benzodiazepine to intubate. I would not use succinylcholine in them. I can use rocuronium, but I end up using midazolam short dose to intubate these patients.
They already have their own neuromuscular blocker. But what about, I think they're asking also about seizures. Yeah, so I think UVA was specifically asking about convulsions. We talk a lot about, you know, lorazepam versus diazepam in the U.S. and probably for nerve agents.
See, the most common agent with which we used to see convulsions was endosulfan. That is an organochlorine compound. Now, we don't see endosulfan anymore. It's banned. It's not available in India. So we've stopped seeing seizures. We do not end up seeing too many seizures now.
Interesting.
But yes, there was a concern about seizures in organophosphate compounds, and I think some of them are related to the solvents which are used to manufacture organophosphate compounds. There were some Chinese compounds which were available in India, and they had a high, they were dissolved in xylene, I believe. So it was probably the solvent which was causing more seizures than than the organophosphate compounds. We've not looked at non-convulsive status. Fine, you've given me another research topic that I will look at non-convulsive status in all organophosphate, severe organophosphate.
Get the EEG machine.
Yeah.
Now, another question about the intermediate syndrome. When they're intubated and, you know, they're, let's say, 4 or 5 days, 6 days out, what do you do to predict recovery, and then what do you do to predict intermediate syndrome?
There was a study from CMC Vellore which looked at the admitting CPK levels, creatine phosphokinase levels, and myoglobin levels in urine. And they correlated that with, if you have a very high level, I don't remember offhand the cutoff which they've used, to say that it's a continuum. If you have a very high level of muscle damage at the outset, which is indicated by high CPK and high myoglobin in urine, these are the patients who would end up developing intermediate syndrome. The other predictive model has come from Sri Lanka, where they've used the repetitive nerve stimulation test. After 48 hours or 72 hours, if the patient continues to be in weakness, they'll do a repetitive nerve stimulation test. And if you find a decremental response, these are the patients who are more likely to end up with intermediate syndrome than any other patients. So you might need to keep them on ventilation and keep on observing them for a longer period of time. Mind you, mortality in organophosphate compounds in a patient who ends up in ICU or has intermediate syndrome is mostly because of the complications of prolonged hospitalization. They die because of nosocomial pneumonia, ventilator-associated pneumonias, nosocomial sepsis. Yes, you may say that the inciting event was organophosphate, but the mortality is because of the secondary complication. Yes.
We have a question actually here from Atlanta. We can speak it up over here.
Have these patients ever been followed on long term, like over the next 3 months for any chronic
great.
or signs?
I did not elaborate on them. We just now finished 2 studies. In one which we looked at the acute stage of all organophosphate poisoning, and we did a SPECT in them, we did a MRI in them, and we found that there is a change in SPECT and in MRI perfusion. There are defects, which clinically, when they've recovered from the acute event, the ones who survive, there is a neurocognitive decline, which you can only test if you use a battery of neurocognitive tests. And over a period of 3 to 6 months, it improves. Since we do not have their neurocognitive functionality beforehand, we can only compare them to the normative data. They never come back to normal. Never. But it's only detectable on the specialized neurocognitive testing. We've shown it with aluminum phosphide as well, and we've shown it with something like snake bite. Now, with organophosphate and with aluminum phosphide, we may say that the poison may have a direct effect on the CNS. But in snake bite, which is neuroparalytic, purely hypoxic, they do have the similar kind of outcome. They have a neurocognitive dysfunction, which improves over a period of 6 months, does not come back to normal.
Please chat your question. For some reason, I'm not sure I'm able to see the hand if it's raised. So if you've had your hand raised, my apologies. I don't know if I know how to see it, but you can just send me the chat. I can see the chat box. Are there any other questions for Dr. Balla about his experience? I guess one common question, I'm sure, amongst toxicologists, what is the highest dose of atropine you've given to a patient?
I showed you. Maximum was 3 grams in a day.
Wow.
So the major now we have in India is atropine dispensed in 100 milligram infusion bottles. So the major problem is if you are not monitoring the infusion, the patient comes with one poisoning and you give him another one. So you're taking care of organophosphate, but if you keep on infusing atropine and do not stop it or decrease the dose, I don't want you to stop it, I want you to decrease the dose. If the patient develops a toxicity, then the patient ends up on the other side. It becomes, kind of anticholinergic toxicity. Agitated.
What is your typical regimen for tapering atropine?
Okay. See, what happens is that you keep on increasing from 2 to 4 to 8, 16, 32. Wherever you find complete atropinization, stop. Then, ideally, what is recommended is that what was the highest dose which you've used, you halve that. And you maintain these patients for the next 3 to 4 hours on that half dose. Watch for toxicity. If they are able to maintain well on that dose, then they probably require that much atropine to control that. If they develop any kind of toxicity, then you, after every 4 or 6 hours, you keep on halving the dose and you come back to a baseline of 2 to 4 milligram or 1 to 2 milligram, whatever is sustainable there. You maintain it for next 24 to 48 hours. And once you stop the infusion, what I do personally is that you shift them over to, let's say, 2 milligrams every 6 hourly or 2 milligrams every 4 hourly. Then next day you decrease it 2 milligrams every 6 hourly and decrease it to 2 milligrams every 8 hourly. And then you stop. You never abruptly stop atropine, because organophosphates would end up, they are lipophilic, some of them, they'll end up storing in the fat. Once you stop atropine, there's a rebound. And we've seen that there are patients in which, because the patient has developed atropine toxicity, you abruptly stop atropine and you find that cholinergic toxidrome coming back again in the...
Okay, so I guess I'll take the last question, because I'm not as mean as Dr. Azim, and I'm not going to pick on participants from this webinar. Is there a difference in the time to onset clinically if someone ingests an oxone versus a thione, requiring activation in the liver?
If you are expecting the early aging.
No, I'm talking about the activation of the organophosphate in the liver to the active, to the oxone. So, for example, chlorpyrifos or
yes.
parathione.
There is you need to be more watchful for these patients, because when they get activation in the enzyme, their presentation might be delayed. So that's why I said that you need to observe them. You don't know what compounds they were using. So you need to observe them for at least 12 hours. We end up sometimes observing them for 24 hours. Even the mildly toxic patients might not give them anything, just observe them, maybe give them 2 or 4 ampoules of atropine and wait. I'm not concerned about muscarinic symptoms as much as I'm concerned about the nicotinic weakness. Because what is going to kill them is the muscle weakness. And if with minimal atropine dose you're able to control their secretions, I'm good with that.
Okay, well, if I don't see any more chat requests, I want to just thank Dr. Bala, thank ACMT for allowing us to use this exceptional platform for toxicology dialogue nationally and globally. Dr. Bala is an ACMT member and will be in San Juan. If you want to talk to him there in person, he'll be there throughout the conference. Again, thank you, JJ, for the opportunity, and thank you, ACMT. We will send you a survey to collect your comments, and we appreciate you taking the time to filling that. Thank you.
Thank you for this talk. I have two questions.
Yes.
Uh,